Okay, well, welcome everyone. Thank you for joining us for this webinar. I'm Dr. Spoonamore. We have the great pleasure of having our famed anesthesiologist as well, Dimiter Arnaudov here. He's going to discuss the immediate postoperative care of the spine patients undergoing surgery. What I would like to do is give everyone a brief overview of some of the aspects of our spine center here at Keck, USC. To start things off, I'll introduce you to some of the spine surgeons and spine specialists in the spine center. I'm one of the more senior members, but we've actually recruited and hired a number of new specialists over the years. And here's the list of the other doctors. Our directors are Jeff Wong and John Liu. Jeff came from UCLA. He had been there for over 20 years, almost 20 years. And John had been at Cedars for 7 or 8 years and at Northwestern prior to that. And it was a very collaborative event to bring all of these surgeons together. And we've recruited some other younger surgeons as well as a number of pain management specialists to really form a very collaborative spine center where we work with all the specialists. And in this case, for our lecture today, we're discussing the perioperative, postoperative care and complications of the spine surgery patient. We really have a multidisciplinary approach, both in the clinic setting, in the operative setting, and also on the diagnostic side as well. We involve all the therapists, radiologists, psychologists, as well as our hospitalists. We really want to collaborate and have a multidisciplinary approach so that we can maximize the patient outcomes and as well as the success of the treatments that we undertake. We have expertise in all of the areas and all aspects of spine surgery, both cervical, lumbar, everything from the smallest microsurgeries and minimally invasive treatments, as well as the maximally invasive surgeries involving deformity, kyphoscoliosis correction, reconstructive surgery, tumors, as well as trauma. We really try to employ a non-surgical technique and approach. We try to really hopefully get patients better without surgery. And so we have a number of non-surgical spine specialists who do a lot of pain treatments as well as injections and other non-surgical treatments. When it comes to operative treatments, we are at the cutting edge where we really try to employ all the newest technologies, not so much relying solely on that, but really utilizing the expertise that we've all come and acquired over the years, but using that to help further maximizing the success of the treatments. Again, we're at a major, medical tertiary care center. We have the benefits of being associated with the Keck School of Medicine, with all of the research facilities and resources that we utilize to help do the bench research to study the basic science aspects as well as the outcome studies that we perform. The principal center is at Keck USC Hospital, but we also, USC purchased Verdugo Hills, and there are a number of outpatient spine center offices that are also utilized by a lot of our spine specialists. So in addition to doing the treatments, we also have a lot of training for the younger doctors. We have one of the larger orthopedic surgery residencies in the country. We have 3 neurosurgery residents per year, and they all rotate through the spine center with both the orthopedic and the neurosurgery specialists. We also have fellowships in the interdisciplinary pain management and physical medicine rehabilitation. We have a lot of medical students that rotate through our service, as well as international surgeons and PhD students who do a lot of research in our department. There's a large international component. We often, especially my colleagues, are very engaged in the international forum, both in Europe and Asia, and even South America, to really discuss and publish our research, as well as collaborate with the other specialists in other countries. And this is just a small list of some of the collaborative efforts throughout Europe and Asia and South America that is actually undertaken at this time. We have a very active research division as well, both basic science and our clinical outcomes that we are very dedicated to utilizing to help improve our outcomes. We have an annual USC Spine Symposium. This year was the first year it had to be virtual, as well as our webinar series, and it was a smashing success, although in the future we hope to have it live once again once we end the COVID crisis here. And without further ado, our first speaker is going to be Dimiter Arnaudov. He's going to speak with us about the immediate postoperative care of the spine patient, and then I'm going to actually delve into the complications for spine surgery itself, and then we'll take questions after that.
All right. Good evening, everybody. Thank you for the kind introduction, Mark. My name is Dimiter Arnaudov, and I'm a neuroanesthesiologist. I've been working at Keck for the last 22 years. I have somewhat of international training. The accent that you hear is Bulgarian accent. It's not fake. It's real. So, I finished residency in Israel. I went to medical school in Germany, then finished residency in Israel, and I've been practicing, as I said, at Keck for 22 years now. So today's goal basically is to just kind of like I'm trying to bring across some of the concerns and the problems that we experience as neuroanesthesiologists when we're taking care of spine patients. Specifically, I'll be talking, as already Mark mentioned, about common postoperative complications. And we'll try also to recognize the factors that lead to those complications and discuss some prevention strategies and mention also some treatments of those complications. Okay, I have nothing to declare when it comes to the financial issues. Let me first briefly define what an immediate postoperative period is in the eyes of an anesthesiologist. We're talking about the time period from the end of surgery to the moment where you basically transferring care to the ICU team or the post-anesthesia care unit team. It's basically a transitional period, and it's unfortunately marked by great vulnerability for the patient. So yeah, how bad could it be, you ask yourself? Things do go wrong, and that's what we're trying to discuss here today. So when I talk about complications, in anesthesia, it's very common to use algorithms, and I'm basically borrowing the algorithm, the very well-known algorithm of the basic life support in ACLS, which is the ABC algorithm. And as you know, A is for airway, going down to B, which would be for breathing and looking for possible ventilatory issues and respiratory insufficiency. Then going to C. C would be for circulation, hemodynamic instability, which is mostly hypotension in the postoperative period. And it's mostly due to volume status. And we're going to discuss that a little bit later. Of course, coagulation is a big issue, especially with patients who are bleeding actively. Cold for a C, again, for temperature. Treating patients who are hypothermic as a result of the surgery or the exposure. Very important consciousness, of course, for all these patients, delayed awakening that might happen, and much more rarely stroke or seizures. Residual drug action from long anesthetic. Long surgery would require long anesthesia, and unfortunately, it happens that those patients also experience some delayed awakening because of that. And E at the end is exposure. Basically, after the surgery is finished and you're uncovering the patient, you have to inspect for possible wounds and injuries as a result of the prolonged pressure on some bony prominences or a face. And at the end, we're going to mention also ophthalmologic complications, eye complications, and the most infamous one is the perioperative visual loss. Okay, so so when we're talking about high risk surgeries, not all patients and all surgeries are created equal. Of course, an 80-year-old patient, let's say, with multiple comorbidities coming for a complex spine procedure with osteotomies and instrumentation on multiple levels will need a very different level of care, of course, as compared to a 20-year-old healthy patient coming for a minimally invasive procedure, let's say a discectomy as an outpatient. So how do we define high-risk procedure? Basically, it's a combination of patients' comorbidities and procedure characteristics. Prolonged procedures, more than 6 hours, multiple levels, circumferential approach, anterior, posterior, or stage procedure. Also, anticipated blood loss of 1 liter and above would go into this category. From patients' comorbidities, advanced age, BMI more than 35, but also patients who are malnourished or sarcopenic would also fall into a category of high risk. Patients with, of course, obstructive sleep apnea, CKD, diabetes, coronary artery disease, etc. So those would be basically the patient's characteristics for that would qualify for high risk procedure. As anesthesiologists, basically, we're kind of like obsessed with the airway, as you can imagine. So the first existential question that we're always facing when the surgery is finished, should we extubate the patient or not extubate that patient? And we're well aware of complications that can occur with even short mechanical ventilation postoperatively. So our goal is really to extubate everybody as long as we can. For that, to that end, it's really important that we assess the airway patency. That's one thing that can actually be compromised during long procedures. We know during long surgeries or when you have a pretty large blood loss, you can also have a fluid shift that can occur. Typically also the oncotic pressure falls, and that would lead to an airway edema, tongue swelling. Also, in addition to that, there might be some injuries to the oral cavity as a result of basically the motor evoked potentials that we're monitoring throughout the procedure, and those patients need to be stimulated during the surgical, the transcranial stimulation that they're getting during the surgical procedure can actually cause a very forceful clench of the teeth. And if there is no oral airway or protection in place, many times we've witnessed very nasty injuries to the tongue or oral cavity. Also, a possible neck hematoma that can occur either from a central line or from the surgery itself, if it's a cervical spine. For a recurrent laryngeal nerve, unilateral injury usually doesn't really do much other than hoarseness, but bilateral recurrent laryngeal nerve injury can actually cause an airway obstruction. Of course, also patients with a history of difficult intubation would the threshold for leaving them intubated would be basically a little bit lower as opposed to a normal airway. And patients who are returning within 24 hours for as a part of a stage procedure, they usually remain intubated overnight. So this is what it looks like when we're talking about airway edema. This is actually the nightmare that can happen. The patients on the left-hand side, you see a normal airway with nicely shaped epiglottis and a good glottic opening. And on the right-hand side, as you can see, the airway edema is significant, and the most dreadful side here, of course, is the glottic opening has been almost shut close by this edema. So patients like that will have a very difficult time moving air after extubating them. So this is one of the dangers that we're facing. So how do we proceed with patients like that? One possible prevention is, as I mentioned before, the oncotic pressure is plays a significant role in building the airway edema alongside other factors. So we can try to maintain good colloid pressure by actually resuscitating the patient with less crystalloids and a little bit more colloids. So basically keeping the ratio below 1 to 3 might help. And there are studies actually showing that it does actually help in preventing airway edema. So by block, we mentioned that to prevent injuries, of course. It's important to inspect the airway before extubating. Could be just a direct laryngoscopy, or nowadays we have video scopes available everywhere, and or fiber optic scope, just to make sure that there is no significant swelling. The cuff leak test, it's mentioned pretty much everywhere that the cuff leak test can be done in order to ensure that the patient can move air around the deflated cuff, and that basically would actually constitute a negative cuff leak test. A positive cuff leak test would be when you deflate the cuff of the endotracheal tube, the patient cannot move air around it. That would be a positive test, and should speak for or against rather extubation of the patient. Unfortunately, that test is has very limited diagnostic value, has very poor sensitivity. You get a lot of false positive in those patient, in the cuff leak test. So if you do it, just take the results with a grain of salt. But nevertheless, I felt that I should mention it. Treatment of those patients, basically a way to speed up the alleviating the edema, basically, and speed up the recovery of the airway. Steroids probably play a role. All of our patients are getting steroids at the beginning of the procedure, in the hope that this will be one of the effective treatments against airway swelling. Also, elevating the patient's head after the surgery as much as is possible. Just have gravity to do its thing for alleviating the edema. Awake extubation is always preferable in situations like that to deep. patients who are awake and following commands and able to sustain head lift are much better equipped to fight partial obstruction of their airway as opposed to patients who are still anesthetized. And even if they're breathing spontaneously, they very often they cannot maintain the patency of the airway once extubated. And of course, when in doubt, we always leave the patient intubated overnight, as I said, reluctantly, but sometimes that's necessary. A good way to handle also when in doubt airways that are, we think that might obstruct after extubation is to use a tube exchanger, which you can see the catheters that are marked with D, E, and F. The tube exchangers basically are just catheters that can be inserted within the endotracheal tube. And after suctioning the airway, the tube is removed. The tube exchanger remains in place in the trachea. And as long as it doesn't poke the carina, actually it's pretty well tolerated. And the patient can breathe with the tube exchanger in the trachea. And then you can assess the patency of the airway. In case the patient doesn't do that well, you can always use the tube exchanger for reintubating the patient safely. So that's one thing that we also do for those patients. The most common cause for respiratory depression is opioid overdose, basically. Since we are conducting total intravenous anesthesia for our patients, as I mentioned, we do neuromonitoring on them, and volatile anesthetics and of course muscle paralysis are relatively contraindicated in cases like that. So we are using total intravenous anesthesia. It's mostly propofol as an anesthetic and an opioid, which intravenous opioid, which mostly is sufentanil. So sufentanil tends to accumulate. The longer the surgery, the more the accumulation, of course. The context-sensitive half-life, as we say, of sufentanil, it's not very it's not very, it doesn't favor actually very fast extubations, especially if you don't plan in advance. There is a way, of course, to do that, but sometimes it happens that our patients, especially when they're at higher risk for respiratory depression, either they're obese or have obstructive sleep apnea, and somewhat counterintuitively, opioid tolerance, high opioid tolerance sometimes also causes prolonged respiratory depression after the surgery is finished, simply because we're forced to give so much more opioids intraoperatively to prevent the patient from moving that at the end of the case, you're literally left holding the bag with those patients and wait for the opioid to get metabolized, which might take some time. So the patients with risk factors for respiratory or pulmonary complications are best monitored in postoperatively in either telemetry or ICU, preferably ICU. And many times you need to also use either a CPAP or BiPAP machine, or nowadays more and more we're using high flow nasal insufflation in severe cases to maintain the patency of the airway. So what other respiratory and pulmonary complications, what other causes can be there? Atelectasis usually that happen in a lot of those patients because of prolonged procedure or positioning. Usually not such a great factor. Patients might desaturate, but it rarely leads to some respiratory complication. We would like to also see saturations more than 95 and carbon dioxide and tidal CO2 of less than 55 before extubating our patients. just as a safety measure. Tidal volume and respiratory rate also play a role, but they kind of like less sensitive to patients to basically really reliably rule out a respiratory complication. As I mentioned, other causes for respiratory failure could be a fluid overload. That can happen in sometimes we're a little bit overzealous with replacing blood or fluids in our patients, or the patient has some underlying cardiac issue, like CHF. And that can lead to fluid overload and pulmonary congestion, even frank edema. Blood transfusions can also hurt the lungs, as you know. Lately we've been talking a lot about TRALI, which is the transfusion-related acute lung injury, or TACO, which is a transfusion associated circulatory overload. Transfusion associated to circulatory overload. Actually, TACO is more often nowadays than TRALI, and occasionally you can see it with, as I said, with large volume overload. Pneumo and hemothorax from line placement need to be kept in mind as differential diagnosis for ventilatory failure. It could be from a central line, but could be also from the surgical injury to the pleura, let's say, or sometimes a segmental artery in thoracic procedures, which can cause a hemothorax. Venous air embolism, although a rare occurrence. As a matter of fact, yesterday we had a case that did fit the description of venous air embolism during a thoracic case. The patient was in a prone position and had a kyphotic lesion. So sometimes when you get a good gradient between the surgical field and the heart, usually more than 5 centimeters is necessary, then you can actually, and you get active bleeding from the venous side. You can actually, it can happen that the air can be sucked into the circulation and make its way to the heart and cause air embolism. As I said, it's relatively rare, but it could happen, and it's worth keeping in mind. C for circulatory disturbances, as I mentioned in that slide before. So the most common, of course, circulatory disturbance is hypotension. And all hypotension in complex spine procedures is usually under resuscitation until proven otherwise. Especially at the end of the procedure, when the stimulation is over, there are no pain from surgical stimulation. Especially when you're flipping also patients from prone to supine, very often you're actually unmasking under-resuscitated patient. You're unmasking hypovolemia. So the result is profound hypotension. Also at that time, many times if the patient is on some baseline vasopressor infusion, that needs to be stopped for transport with the same result. You get significant hypotension, and that is something that usually happens with a lot of intraoperative blood loss. So our goal is always to maintain mean arterial pressures, especially in complex spines, especially in cervical and thoracic cases. We're trying to maintain mean arterial pressures of 85 and above. So anything below that would be considered also a hypotensive response. Unfortunately, the blood loss intraoperatively is not that easy to measure. And it's really a lot of vigilance is required on the side of not just anesthesiologists, of course, also surgeons. my mantra is always that vigilance, anticipation, and communication are the most important things in our profession. So you really have to look at the suction canister, the cell saver, salt labs and sponges. Everything needs to be looked at and calculated and counted towards blood loss. Hemodynamic parameters, of course, as blood pressure, which is not quite reliable. But nowadays, we're using more and more arterial wave contour analysis, which is the pulse pressure variations and stroke volume variations, with a pretty good success, actually, to assess the intravascular volume of the patient. And of course, you look also at the labs, especially acid-base status and also lactate, and of course, the hemoglobin and hematocrit of the patient. The therapy is clear. You have to resuscitate the patient even further if postoperative hypotension occurs. And we're utilizing also, of course, vasoactive drugs as a temporary measure until we catch up with blood transfusion. Hemorrhage is also, as I mentioned, it's very, very important complication that happens in those surgeries with high mortality. Recently, blood transfusions have come under increased scrutiny, so to speak, because of questioned safety or benefits. Also, the cost plays a big role. There's I think I read somewhere that $10 billion a year, the cost of blood transfusions in the United States. And lately, also, we've been experiencing some shortages of blood supply. So, in addition to that, what we mentioned TRALI and TACO as transfusion-related complications, and they've been getting also a lot of attention in the literature. In other words, there's kind of like pressure from the blood bank and the administration not to transfuse patients excessively. Unfortunately, that is getting sometimes the wrong message to people who work in high-risk spine and patients who are really bleeding profusely during those cases. And we now and then we are encountering really very sick patients and who are bleeding profusely, and the transfusion has been delayed for different reasons, and it's really hard to catch up with those patients once you fall behind. One thing is really for sure that actively bleeding patients, especially intraoperatively, the decision to transfuse shouldn't be based just on one number, let's say a hemoglobin threshold of 7, but it should be actually be a thorough evaluation of the whole clinical situation, and it has to also take into account laboratory findings and the clinical picture that is happening right now. So coagulopathy is another problem that could complicate treatments in patients, especially patients who have lost a significant amount of blood. The rate of coagulopathy is only 1% in patients who are not bleeding profusely, but could be up to 50% if the EBL goes above 3 liters. The major risks are the hemodilution that can occur with infusion of fluids, but also with transfusion of blood. If we're not transfusing platelets or FFP, that actually can occur, although rare. I must say that that hemodilution usually affects the platelets, but rarely the blood factors. the coagulation factors. Acidosis and hypothermia. Hypothermia does inhibit platelet aggregation, so patients really need to be warmed up actively. And acidosis can interfere with thrombin enzymatic activity on fibrinogen, which also needs to be corrected. The acidosis needs to be corrected for that purpose. Lately, we've been using thromboelastography, which is a very good way of telling, and it's pretty fast. You're getting actually results within 20 to 30 minutes. And it's very useful, not just because it gives you a diagnosis, but also tells you what exactly to transfuse in order to fix the problem. And that's been really very helpful. Cardiovascular complications are also notoriously hard to manage, and one term that we are using frequently nowadays is MACE, the major adverse cardiac event. Basically, it's the occurrence of myocardial infarction, arrhythmias, or even cardiac arrest. It happens in 1 to 2% of those cases. However, it can go up to 8 to 10% if the patient is bleeding profusely and if you have a large blood loss. And then MACE can occur even in patients who don't have actually risk factors as measured by the revised cardiac risk index. Two other, actually one laboratory measurement that I think it would be very helpful in preoperative risk stratification is the BNP, or the brain type natriuretic peptide levels, or the NT-proBNP. Basically, the NT-proBNP has a little bit more sensitivity than BNP, but these are great tools when you're trying to stratify, to find out if the patient has any significant clinical heart disease in the preoperative screening. So it's really highly recommended. We actually intend to do that in all our patients 45 years and older for complex spine procedures. The diagnosis of MACE or MI or some significant cardiac injury post-operatively is through EKG changes and troponin levels that we routinely take in most high-risk spine cases. And the treatment is supportive. These patients might even need some percutaneous intervention in case of overt MI, like a STEMI infarct. They might need to go to the cath lab as a salvage procedure. Another term that I briefly want to mention here is the MINS, which stands for myocardial injury after non-cardiac surgery. And spine cases, of course, are no exception to that. It's basically, those are patients that will experience troponin level elevations without any signs or symptoms of ischemia. And apparently this has some real implication, has real implications for the outcome of those patients. And it's something that also it's really worth considering in spine cases and any major surgery, really. Those patients really should probably get the troponin levels after the procedure, even if they haven't experienced any major hemodynamic disturbance during the procedure. Consciousness is another important parameter, and also goes into the scope of postoperative complications, especially when patients fail to regain it, failure to regain consciousness. Again, most of the cases, it's just because of residual drug action, but sometimes could be also something more grave like intraoperative stroke or even seizures. Tranexamic acid, which is an antifibrinolytic agent and we frequently use, if it's given in high doses, can actually up to 6% cause grand mal seizures in those patients. Usually you don't see it right away after in the postoperative period, but it can be seen a little bit later in the ICU. Luckily, we don't really use very high doses of tranexamic acid, but it has been clearly described in the literature. We like to extubate our patients, as I mentioned, awake. They should be at least following commands and have a gag reflex to demonstrate that they can protect their airway. So the stroke that I just mentioned briefly, the incidence is actually not very high, but this is actually if you look at the brain images after those surgeries, many times you find actually covert stroke up to 10% in this population, which is very significant. The stroke can be ischemic or hemorrhagic. Most of the strokes are ischemic. 80–85% of the strokes are ischemic. One specific area that it might happen is with ACDF procedures, cervical spine surgeries, with prolonged use of self-retaining retractor. Apparently, if there's a lot of pressure on the carotid artery for a prolonged period of time, that can actually result in ischemic stroke. Hemorrhagic stroke has been linked to a CSF leak, leading to intracranial hypotension. Apparently, the CSF leak has to be significant or prolonged in order for this to happen. Other instances here of possible strokes, although very, very rare, is vertebral artery injury with lateral mass screws in C1 or pedicle screws in C2, posterior approach to spine, to cervical spine. And of course, patients who do not regain consciousness but show some focal deficit after surgery, we take them to a brain imaging, usually a CT scan, just to make sure that we're not missing a stroke. Hypothermia is pretty common, unfortunately, in spine cases, just because of the huge exposure that these patients are getting, and also because of the fluid shift and the bleeding. We don't really have too many ways of warming these patients other than just increasing the room temperature or using underbody full mattress, warm mattress. Unfortunately, you cannot use forced air, warmed air on them for obvious reasons during the procedure. Hypothermia is bad for a few reasons. One is, of course, shivering and increasing the oxygen consumption. Another one is that causes coagulopathy, as we mentioned already. If it drops significantly below 33 degrees, which is very rare, actually, usually they're around 34, 35, but it can cause arrhythmias and myocardial dysfunction. Cold diuresis will cause some abnormal electrolytes and hyperglycemia. And later on, there's an increase of infection rate if you don't effectively warm up those patients. And if the temperature is below 34.5, usually we don't extubate those patients. We need to bring them to the ICU intubated. So positioning-related injuries, as I said, E for exposure. This is one of the surgeries. Once the surgery is finished, we look for possible injuries. The usual place is either the face, the eyes, lips, tongue, also pressure wounds to bony prominence. And the prevention is mostly by padding and frequent checks during the procedure. Repositioning of the endotracheal tube, especially if the patient is in prone position, that's quite tricky to do. But gauze padding of the lips sometimes works just fine. And also the blood pressure cuff, which you typically don't utilize that much during the procedure since most of those patients do have an arterial line. Hypotension is avoided, of course, not to cause any hypoperfusion and basically add an additional, as we say, insult to the injury, like double whammy for places where where you have actually hypoperfusion because of compression. And all wounds should be documented and treated, and these are a few actual examples of bad things happening in those patients. Perioperative visual loss. Okay, that's an entity that many patients and sometimes surgeons also are not aware of. Perioperative visual loss, unlike what many people think of, is not as a result of external glow compression, which can happen, but it's rare. And then we refer to it as a central retinal artery occlusion. And it's usually unilateral where the pressure was. But most of the cases actually of postoperative visual loss, which is, as I said, very rare, 1 in 3,000, 1 in 4,000, very, very rare, but really a devastating complication, is actually, the reason is ischemic optic neuropathy. And we don't know why is it happening. We actually, it's usually evident immediately after awakening. It's painless, and it's usually bilateral. We could identify, the risk factors that have been identified with ischemic optic neuropathy, and I've listed them here. Basically, those are overweight men that undergo prolonged procedure with large blood loss on a Wilson frame and have received a lot of crystalloids and much less colloids. Again, the decreased oncotic pressure that we discussed earlier. So those would be patients that are that will have risk for that rare pathology. The 2012 practice advisory actually recommends to test frequently for hematocrit in high-risk procedures where you have a lot of bleeding, although it's not quite clear what the best hematocrit would be for those patients. Minimizing venous congestion, in other words, try to position the patient in a way that gravity doesn't really pull blood into the face and to a periorbital space. And also try to maintain oncotic pressure with giving more colloids than crystalloids. Also, long procedures can be staged, and these patients probably should be also informed about the risk of postoperative visual loss, patients who are undergoing these high-risk procedures. Pain control, also a very important portion of our job in the immediate postoperative period, especially when the patients are waking up for a very, very extensive procedure. Many of those patients, as you can imagine, are also opioid tolerant. So it's important to have thought about this even before the surgery is finished. So you can start loading them on some methadone. Ketamine is usually given as an infusion and does an excellent job in controlling postoperative pain. Precedex or dexmedetomidine as an alpha-2 agonist also is utilized, especially in ICUs and especially in patients who will remain intubated. It has the advantage of sedating the patient, in addition to analgesia, sedating the patient without basically causing respiratory depression too much. And oral medications also have an important role to play, and we are utilizing them actually, except Toradol, ketorolac, which actually has can interfere with platelet function, but also with prolonged use probably interferes with bone healing. And at the end, the transport to PACU or ICU is also a very critical moment. Again, we go with that checklist ABC to make sure that we haven't forgotten anything, but common sense measures are rescue equipment, of course, and rescue medications that you have to have with you for the transport. And it's very, very important to have a good communication with the ICU personnel and for the purpose of transfer of care. Thank you very much. That was it.
Thank you, Dimiter. Very good talk, very detailed. We will take some questions at the end. However, I'm going to touch on the specific spine surgery complications, and then we will take some questions at the end here. So I just have to figure out how to share the screen here. Can everyone see my screen there?
Yes, we can see it.
Okay. So I'm going to talk about the specific complications in spine surgery. Dimiter did a very good job of going over all of the things that need to be taken into account as the anesthesiologist while we're doing the surgery, and especially in the immediate postoperative period, which is certainly the highest risk time period. So in looking at this, what exactly is a complication? Well, the surgical complications are defined as any undesirable or unintended effect that occurred as a direct result of the surgery. However, most patients view anything that is a negative, whether it's direct or indirect, that happened to be associated with the surgery. So that's why we really need to pay attention to the entire patient throughout the entire course. So one thing I'll discuss is that spine surgery and spine problems are very common, and we do a lot of this every day here at USC. Fortunately, the risk of complications are quite low in general terms, and that generally the surgery is quite effective and has good outcomes. So as we discussed, a lot of times when you have a back problem, we try to treat it conservatively. And a lot of times for basic spine problems, doing nothing actually works quite well. There's such a high prevalence and incidence of back problems in the United States and the world that if we operated on everyone, we'd be doing surgery 24 hours a day, 7 days a week. Fortunately, most of these people get better without surgery and with simple conservative care. In one Swedish study, 80% of the population experiences a disabling episode. And here in the US, Rick Deo published data that shows at least 60 to 80% have some episodes of back problems, and 1 to 2% ultimately require surgery. In terms of the surgery choices, it can be something such as a microsurgery or a small decompression, up to multi-level laminectomy, decompression, and fusion surgeries with instrumentation. So in terms of the overview, complications may be big or they can be small. A lot of the surgeries we do can be either high risk or classified as medium or low risk. As we've discussed, the complications can occur during the surgery or in the postoperative period, either immediate early or even some late occurring complications. And another way to look at it and analyze it is some complications resolve and have no ultimate untoward effects, or there may be very severe long-term side effects. So overall, both as the surgeon and also what we explain to the patients, we'd like to kind of quantify or qualify the types of surgeries and what the risk associated with that would be. Certainly, we'd always prefer to do a low-risk surgery, such as a microdiscectomy or a micro decompression or some minimally invasive surgery that would have low risk, generally speaking. However, depending on the condition, it may require a major reconstructive surgery, and certainly some of the tumor surgeries that we do, or surgeries that have infection, or major reconstruction surgeries that involve multiple levels or osteotomies may have very high risk. So we're always trying to weigh the risk versus benefit for the surgeries. And it is very critical, it's very critical to discuss these risks with the patient in detail. And I often also try to involve the family so that everyone is on the same page and understands what they're getting themselves into. The surgeries, the surgery complications may be more medical, or they could be specific to some of the surgery techniques, or there could be some iatrogenic side effect that's somewhat unrelated, but still a direct result of the surgery. We've heard a lot of the side effects that can occur as a medical or kind of anesthetic issues that may arise that can be dealt with. However, there's certain other non-anesthesia issues that may have urinary retention or pneumonia postoperatively. But I'm going to discuss some of the more specific complications that can occur related to the actual spine surgery itself. Overall, the most common reported complication typically is infection. However, it probably should be listed as incomplete pain relief. The majority of the surgeries that we do as spine surgeons is to treat pain problems that may also involve neurologic dysfunction or numbness or weakness related as well. But certainly if we do a surgery and the patient doesn't get all the pain relief, then it's often viewed as a side effect or a quote complication. Other things that we really never want to have is doing the surgery at the wrong level or things like that. In general, just to take a step back, some of the complications that can occur in a general medical practice or even spine surgery may be simply related to the diagnosis. Maybe it's a misdiagnosis, it's a delayed diagnosis, perhaps the imaging that is reviewed is not interpreted correctly, and the doctor may not correctly diagnose it, or perhaps not order the right test to come up with the right diagnosis. So, and then sometimes related to that, you may have an incorrect treatment that's recommended, or perhaps the treatment is just not the optimal treatment that's carried out, and then may ultimately result in a complication. I'm here to focus on mainly the spine surgery complications, and as part of that, for the preoperative workup, we really try to take into account the entire patient condition, do a very thorough history, physical examination, appropriate preoperative imaging, possibly EMG testing, and a full medical workup if needed to arrive at the correct diagnosis. And then we also do all the things that we'd like to do to minimize or prevent the intraoperative complications, as well as any type of postoperative complications. So we always like to say we like to prevent all complications, but really It's about minimizing the complication. And if we do in fact get it, we want to recognize it and treat it effectively. So one of the big problems or things that we want to avoid is any type of delayed diagnosis of a complication, or missed it, or an incorrect diagnosis of the complication. And so we want to make sure we order the correct testing to identify the complication and then institute the correct treatment for those complications. So even though we always try to prevent all complications, it's generally impossible to prevent it. We always strive to do that, and we will try our hardest, but inevitably we'd like to minimize the risk of these complications and then treat them appropriately if and when they occur. So as part of our prevention or attempt to prevent these, here at USC and our colleagues, we try to send patients to a preoperative clinic and have the anesthesiologist evaluate the patient to really try to look ahead and prepare so that anything, and as Dimiter said, anticipate any problems that could occur, and if needed, have a full medical workup and any type of cardiac or pulmonary workup, and possibly even a hematologic workup. In terms of what I do as the spine surgeon, we really try to properly select the patients, diagnose the patient with the correct diagnosis, identify the pain generator, as well as select the correct surgery for the patient, which often involves proper planning, carrying out good surgical technique, and post-operative care. Part of what we do here at USC and a lot of centers is to look at the indications, do a full preoperative workup, and any testing. We often have a high-risk conference here every week, 1 to 2 weeks at USC with our anesthesiologist to really vet any patients that may be high risk and make sure that they're properly worked up. We also generally review all of the cases, both pre-op and post-op, with all the orthopedic and neurosurgery spine surgeons, and discuss any of the special high risk or nuances of the case, any complications, and try to help avoid those, and discuss any things that were done if we did in fact have those complications. We try to work as a team in the operating room. A lot of times for complex cases, we might have 2 surgeons working together. We often institute neuromonitoring. We use the technologies available, such as the C-arm, O-arm, or robotics. We do all the things we can do to control and lower the infection rates. And then we study the outcomes to hopefully help improve the success rate of these surgeries. We have postoperative pathways that help guide the postoperative course. We have hospitalists that are dedicated to our spine service to maximize their medical rehabilitation. We have occupational therapy, physical therapy pathways that help dictate their postoperative course. And we also collect the outcomes data to, as I said, further optimize this. And I'm going to get into just a few examples specifically of the cases. When we're doing sometimes these complex anterior exposures, we're working around the great vessels that present high risk. We'll work with and collaborate with our vascular surgeons to do the approaches, and as well as sometimes send them to for vascular surgery consults preoperatively to help stave off any possible issues with this. We'll use neuromonitoring throughout the surgery, and that may indicate any type of neurologic irritation. And in relation to anterior lumbar surgery, we will use pulse oximetry on the extremities to make sure that we're not occluding the blood vessels. And certainly we're analyzing the preoperative imaging studies, CT, MRIs, to make sure we know the dimensions so that we're not encroaching on any of the neurologic or vascular structures, putting those at risk. And these are just a few cases that may illustrate some of the things that could occur, even cases that you think should be low risk or no risk. We think of typically epidural injections or other less invasive treatments. This is an example of a caudal epidural. And then ultimately, the patient had persistent pain and swelling, and an MRI revealed actually an infection that developed postoperatively. Even in discography, these have risk that can develop into an infection or other complications. Sometimes you'll do the surgery and the incisions heal well, but you may have actually more skin inflammation or problems just due to allergic reactions of the skin to some of the dressings that can be applied. When it comes to fusion, we always discuss with our patients that they will often have loss of range of motion and increased adjacent level disc degeneration and stress that could lead to additional surgery in the future. There's risk that the patients will have inflammation or some type of instability that could develop postoperatively. And then there's always risk with instrumentation that's placed, even though we try to utilize all the imaging studies intra-op as to guide us. Sometimes there can be complications with the hardware. This is one case where the patient was laying in the prone position and had a pressure on the head. And another patient developed a hematoma after a cervical spine surgery, just to give a couple examples. And certainly during some of the cervical spine surgeries, you're working next to the esophagus and trachea. There can be dysphagia and dysphonia that develop. So as I've discussed, I didn't get down to the granular level for all of these, but we take a systematic approach to addressing these. We know that these complications can happen. We try to anticipate and prevent these and minimize these. We definitely try to do everything that is reasonable to prevent them. And we often, at times, will take extraordinary measures to try to prevent or minimize these as well. Certainly, we anticipate that these could occur. Therefore, when they do occur, we recognize them and we institute the appropriate treatments for these complications. And certainly, we want to provide the safest and optimal outcome for our spine patients. So I appreciate everyone's time. I know we went over time today. We will take questions from patients or from our audience.
I don't see any questions in the Q&A. I see that Dr. Murray has a hand up. Let's see.
So I don't see any specific questions. I will ask Dimiter a question that's come up in previous lectures on this. Kind of a two-part question. What do you consider to be a high-risk patient? And on that note, what is some of the comorbidities of a patient that worry you the most as an anesthesiologist?
Yeah, As I mentioned, basically, there are a few things. I mean, honestly, if I have to just answer off the bat, the worst pathology or the worst comorbidity of a patient that I'm always afraid of dealing with is pulmonary hypertension. That's probably by far the hardest to deal with. And has a pretty high risk for morbidity and mortality for those patients, and they're notoriously high to manage intraoperatively, especially if we're talking about severe, even moderate to severe pulmonary hypertension, because there's so many things that you do during the procedure that actually can make the patient worse and not better. That will be one thing. Of course, other comorbidities as any cardiac comorbidity that is not very well controlled or optimized would also pose a great risk to the patient and a great challenge to anesthesia management. As I mentioned, also obstructive sleep apnea sometimes could be difficult to manage postoperatively, especially. Although nowadays with CPAP machines and high flow nasal insufflation seems to be less of a problem. But yeah, if I have to choose, I would say pulmonary hypertension is probably the worst one. Luckily, we don't get that many patients with pulmonary hypertensions, but that will be something that always scares me.
Well, I really appreciate everyone's time today. I know we went over. I hope everyone has enjoyed and learned some more about some of the general and anesthetic issues and complications, as well as the spine surgery specific complications. And I believe this will conclude our webinar today. Thank you so much for joining us.
Thank you.